We are going to get started, and this panel, or this session, is going to be three different speakers, and we're going to be doing 15 minutes each, and then 5 minutes at the end of each speaker for questions, and hopefully, again, you'll just pass those up on the note cards. So the first speaker that I'm introducing is Dr. Balkozar Adam, and she is currently working at the University of Missouri-Columbia as a child and adolescent psychiatrist, and is a clinical associate professor of psychiatry. She's also a distinguished fellow of both the American Psychiatric Association and the American Academy of Child and Adolescent Psychiatry. And so let's give her a warm welcome, and she can begin her talk.
Thank you very much. I appreciate your presence here. Assalamu alaikum. Good afternoon. So today I'm going to talk about the addressing mental health needs of Muslim refugee youth. Here. Okay, my objective for today is to discuss the special needs and cultural stressor experienced by Muslim youth refugee, and to talk about the challenges that we meet when we meet with this patient, and identify the impact of their culture and immigration status on their mental health, as well as to become familiar with evidence-based practices that we can use in making the diagnosis and the treatment. Okay. So I'm going to talk about the patient that I treated. I called him Zain. He was a 17-year-old boy. He came from a war-torn country from the Middle East. I saw him after 6 months from his arrival. He witnessed airplane dropping bombs in his neighborhood. He witnessed dead bodies on the street, and many of his family members were killed. At one point, he and his family hid in the bathroom and just asked God to save them, because they thought they are already going to die. The school were closed because of the war. Because he was an older adult, he had to hide from the soldier who wanted to recruit him, or from the terrorists who wanted to recruit him. So after a long time, the family were able to move to a different country where they were treated with disrespect, they faced poverty and discrimination. The last time he was in school was in the 6th grade. At that time, soldier came to his school, hit the kid with metal bars. And when he went to the interim country, he could not go to school because the family did not have money to pay for the bus fare. When he came to the United States, he has no English. He worked as a custodian person. He stopped playing soccer, become more depressed, and isolated himself from his family. A refugee worker referred him to me because I understand his culture, religion, and language. She was concerned about depression. She was worried that he was even irritable with his 3-year-old brother. Because he does not speak English, it was important to make sure that he has a translator. His mom, because of the stigma, needed a lot of encouragement by the refugee worker to bring him. Her main concern is his education. Education is very important in Arab countries, not that he has PTSD. So I have to meet the family where they are. I tell them, okay, I'll help him go to school. The mother was worried to tell me what's going on in her country because she was afraid that information will go back and the government will retaliate against her family. So I have to tell her about confidentiality. She wanted to be with people from her culture, so this is not the time to encourage assimilation. Be with your family. With his insurance, and it took a long time to come to see me, I have to be aware of untreated trauma. Family has no car, so we have to work on finding resources for the family. His working diagnosis was depression, although I suspected PTSD. He told me about seeing images of dogs eating dead bodies. He told me about a parent carrying the hand of his dead daughter, saying that's all what I have left from my family. And because of the stigma, I have to gently talk about medication and therapy. He was telling me that everything is fine, عادي, like everybody has been through this, so no problem. So we have to consider that we are at high risk of emotional disturbance and mental illness, especially in children and youth who are trying to go through the identity formation as well as adapt to the new environment. When there is significant trauma in their country and they have to have a lot of stress here, that will make their risk also higher. So moving beyond the boy, looking at the big picture, I want to discuss a couple of definitions. An immigrant person is a person who was born outside the United States to a non-US parent. A refugee is a person who had his legal status granted outside of the US because of experiencing persecution. When the immigration is reluctant, especially if the immigration is reluctant or imposed, they are at more stress and more disposition of becoming mentally ill. They are not prepared. They have to learn a new environment. They have to learn a new language, a new culture. All this increases their stress and their risk of developing mental illness. I want you to look at this graph here. There were 3 recent waves of forcibly displaced people in the world. First, in the mid-90s, that was the Rwandan genocide, and then in the 2000s, that was the war in Afghanistan. 10 years later is the war in Syria. So I want to share with you that immigrant children and children born to immigrants constitute 26% of the population under 18. They are increasingly from non-Western countries. The population of immigrant and refugee in the United States has been increasing in the past 30 years, and there are over 61 million immigrants living in the US. This is an outline of the refugee experience as reported by the National Child Traumatic Stress Network. It is divided into 3 sections. First, the trauma exposed to in the country, and then the risk factor during the pre-flight, flight, resettlement, and then they also have protective factors. So the risk factor during the pre-transition period, they are exposed to wars, violence, torture, starvation. During transition, they are forced to separate from their family. They are spending years in refugee camps. They are afraid of being detained or imprisoned. The post-resettlement, they have to deal with acculturation stress, finding job, finding education, and they are discriminated against because of their ethical, cultural, and religious identity. So, refugees have to navigate several things, but they have to survive first. So first they have to get a job, they have to get a car, they have to get a house to live in, and about preventive care or pre-existing medical condition or mental illness, these are not high priority for them. So they have special needs. We need to make sure that they get their education, their language, their vocational training, their social support by the community and by the religious background, and medical health needs. So refugees go through 12 long, exhausting steps till they come here. But when they arrive, we found that the resettlement resources, that cultural and the linguistic preparation for them, they are not screened systematically for mental illness. The family are facing a lot of stress. The health-seeking behavior is different. They don't know the difference between outpatient, urgent care, and emergency room. The accessibility of treatment and the way of treatment approaches are different. And mental health concept is different for them. They think that a person who is mentally ill is a person who is psychotic. So the stigma of mental illness or being labeled crazy keep them from seeking mental health. So we need to consider using other things like stress or adjustment and not using medical psychiatric diagnosis when we talk to them. Because of the language barrier, it's good to choose words that can be understood by them. For example, Syrian talk about depression as black snowball, something like that will help them. And use a professional translator, understand the impact of trauma on their understanding, and if you can get more support from their culture, that would be great. This shows the mental condition divided by the country of origin and culture. You see that mental conditions are worse in Iraqi, then followed by Sudanese, and then followed by Afghani refugees. The refugee youth are exposed to post-traumatic stress disorder, depression and anxiety, panic disorder, adjustment disorder, and somatization disorder. And the incidence of diagnosis varies depending on their population and their experience from their culture and when they were in their country. Different studies have different rates of PTSD and depression. So I would like for you to look at this. This is how a refugee mother thinks about her child being diagnosed with mental illness. It is really very hard for them because they feel it is a big loss for them to come all the way and then the child have mental illness. So although they have loss of rest, they have selective resiliency. They are hard worker. They made it here, others did not. The culture provides them with support. A study showed a correlation between acculturation attitude and good global self-worth. So now the tools that we use when we work with refugee youth. The American Academy of Child and Adolescent Psychiatry practice parameter for cultural competence in child and adolescent psychiatry practice is a very important and a very good tool to use. Then the DSM-5 culture formulation, a culture formulation interview, and then UCLA PTSD reaction index and the child revised impact of event scale. So this is a quote from the practice parameter of cultural competency. I felt it really reflects what we talked about. The practice parameter has 13 principles dealing with things that clinician can do while helping a culturally diverse patient. Include things like language, like developmental differences, like stereotyping and prejudice while dealing with these patients. This is one of the practice parameters. This is principle 6. Clinician should assess a history of immigration loss or trauma or community trauma while doing the assessment of that patient and address this trauma in the treatment. So DSM-5 has a couple of things. One is outline for culture formulation, and then the culture formulation interview, which is divided into two sections. One is the core interview, when you ask 16 open-ended questions to the patient himself, and then the informant interview, which is 16 open-ended questions that you ask the people that know that patient from his environment, like his parents, his a caseworker, people that knows him. So this way, the patient feels supported, and you get also the other part of the coin from the other patient, family member, to tell you how they see him. And then they have the 12 online supplementary modules. One of them is addressing the immigrant and refugee. It asks more in-depth questions about this particular population. And there's price 8, which is the PTSD symptoms, and there's price 13, which is a more extensive form of this tool. Very helpful. So in 2018, I was granted the ACAP Advocacy and Collaboration Grant, and that grant, I called it Promoting Refugee Mental Health. It was part of the St. Louis Regional Organization of Child and Adolescent Psychiatrists in collaboration with the Missouri chapter of American Academy of Pediatrics. So I developed a video, and the video practice parameter, wonderful, and the cultural formulation and cultural formulation interview. It is it is a time consuming, so you don't have to do it during the first assessment. You do part of it every time. So it is very good tool.
Thank you very much.